Christina?
Good evening, everyone. Due to unforeseen circumstances, I've been asked to fill in for Dr. De Meyer, and at the last minute. But however, it is an honor for me to welcome everyone to this session, and especially to all the participants, but also to our esteemed guest, Dr. Lesego Ndhlovu, who will be introducing the topic to us. GECO is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. And these sessions are held weekly on a Wednesday. The chat will be open for questions. Just for introductions, I'm Christina Hadji-Nicolau. I was a former division head for pediatric gastroenterology, University of the Witwatersrand. And although retired, I'm still involved in especially the training of fellows in pediatric gastroenterology, but primarily undergraduate teaching as well. Dr. Lesego Ndhlovu is well known to both the University of Witwatersrand, but also the Cape Town team as well. And she's a private gastroenterologist, and she'll be introducing the topic to us, something which she considers not as rare as we initially thought. Looking forward to an interesting discussion. Thank you.
Good afternoon, evening, colleagues. Thanks, Prof, for the introduction. Yes, my name is Lesego, and I'm going to present a patient who certainly got me thinking, and in many respects, her story is not yet over. So she's an 8-year-old girl who I saw at the practice in 2023. And she has a condition called Emanuel syndrome, which is a very rare chromosomal abnormality. And she was brought by her mom with a history of recurrent abdominal pain. It was specifically right upper quadrant pain. Of note, the child is nonverbal, but mom gave quite a consistent history of the abdominal pain, of the character of the abdominal pain, or the location being right upper quadrant. And she would have these paroxysmal episodes that would come and go, and they'd lasted over the last couple of years. The pain was worse with fatty foods, and the patient would often have these severe episodes of vomiting, often requiring hospitalization for intravenous fluids, antiemetics, pain medication, pain management intravenously. They also gave a history of some fever accompanying some of these episodes, although not all of the episodes. And there was also intermittent jaundice with these episodes. Mom also gives this history of having the child having very sandy stools, at times acolic stools, and there was also a history of pruritus that was associated with these episodes. But the episodes would vary, so not all would have this full constellation of symptoms. The child also had struggled with weight gain, despite receiving nutritional supplementation through the gastrostomy tube. So she had quite a significant past medical history. She was a late prem at 36 weeks and had intrauterine growth restriction with a birth weight of 2.57 kilograms. Mom reports a bit of a tricky pregnancy. She herself had struggled with hyperemesis gravidarum. She had oligohydramnios. And because of the preeclampsia, the patient was delivered by cesarean section. She had antenatally diagnosed cardiac lesions, and then they were postnatally confirmed as patent ductus arteriosus, a large atrial septal defect, and mild pulmonary stenosis. And over the first sort of couple of years of her life, she had a number of cardiac interventions and surgery to repair these congenital cardiac lesions. She also has a history of difficulty with feeding, had and has a gastrostomy tube in, and she has quite severe food protein induced enterocolitis syndrome, for which she actually required an amino acid formula. She has her sister also has quite significant IgE mediated food allergens. She also has multiple congenital abnormalities. She's quite dysmorphic. She had a cleft palate, which was repaired. She has 13 pairs of ribs, bilateral hydronephrosis, and occasionally struggles with recurrent urinary tract infections. She has an anteriorly displaced anus as well as preorbicular tags. So after seeing her, she was 8 years old. Mom, I had given this history of quite some time. I went back and reviewed all the imaging and bloods and workup that this child had had with all these episodes of hospitalization. And I mean, she was being admitted every 2-3 weeks. And just to maybe orientate ourselves on what a normal gallbladder should look like, this diagram is annotated accordingly. And this is on ultrasound, and one can appreciate that these are her ultrasounds, and these are two sonars done in 2014, which was within her first year. And these are actually done on separate days, but you can appreciate the abnormal configuration of the gallbladder in both images with septations, and actually all the previous sonars that looked at the liver and the gallbladder commented on the abnormal configuration, and this was sort of consistent over the years. And this is just an excerpt from one of their reports that references the gallbladder shows slight septations relating to the fundus, with the impression of small cystic areas seen related to the fundus and also adjacent to the neck of the gallbladder. And they've queried if this was something developmental. So this was what her sonars already back in 2014 had showed. All right, so on examination, she appeared chronically unwell, and she was also wasted. At the time I saw her, she did not have jaundice, neither did she have digital clubbing. However, she did have some pallor. Abdominal examination, she had the Mickey in, but it was otherwise, she did not have any abdominal distension, and otherwise unremarkable abdominal examination. Cardiovascular wise, she had the sternotomy scar from her previous cardiac surgeries, but otherwise, a fairly normal chest, CVS and respiratory examination. In terms of her neurological examination, she had just syndromic features. She was completely nonverbal, and she also was not mobile, and she used a buggy, and her mom sort of helped maneuver her, and she had quite significant truncal hypotonia, which was associated with her syndrome. In terms of her growth parameters, her weight was 14.3 kilograms. And remember, she's 8 years old. Her weight for age plotted below the -3 Z score. Her length was 107 centimeters. So her weight for length below the -3 Z score. So she was severely underweight and severely stunted. And then her weight for length Z score was between -2 to -3, so she was moderately wasted. Just worth noting that she was plotted using the WHO growth standards charts, and not the not special growth charts for children with Emanuel syndrome, as these charts have not yet been validated yet. So I assessed her as this 8-year-old girl with Emanuel syndrome, with the background of congenital cardiac lesions, which have been repaired. She has quite significant failure to thrive, and she presented then with about 2 years ago with this recurrent right upper quadrant pain, and this what looked like a congenital abnormality of her gallbladder, whether it was related or not to her underlying condition, and how this related to the recurrent episodes of right upper quadrant pain. I was trying to piece it together. So I was suspecting, did she have stones? Was she having episodes of recurrent pancreatitis? If so, were these caused by stones or caused by something else? Did she have cholecystitis? Or could she have cystic fibrosis? Potentially, especially given the failure to thrive. So I sent her, we did some bloods on her, as well as stool test, stool for stool elastase, and then she got an ultrasound, which she was fortunate enough to get the next day. And this is her ultrasound from the following day. And I think, again, one can appreciate the abnormal configuration of the gallbladder with septations. Only this time you can appreciate that the wall is there's gallbladder wall thickening, and these sort of white echogenic sort of lesions. Those are, she had some gallstones. So the official report said that she had echogenic sludge and small calculi that filled the gallbladder, and the gallbladder wall is thickened with comatose artifacts. And then they said suggestive adenomyomatosis, which essentially is just hyperplastic changes involving the gallbladder wall. She subsequently got an MRCP. There was a bit of technical delays with that due to previous cardiac surgery and coils. But this then showed that she had several folds and septations in the gallbladder, in keeping with the multiseptated gallbladder, and the gallbladder was assessed to be slightly small as well. So then we understood that she had this multiseptated gallbladder. The rest of her blood work was essentially normal. Full blood count, amylase, lipase were all normal, and her stool elastase was also normal. So after I fed back to her mom that, hey, we did the sonar and we found some gallstones, mom subsequently sent me these pictures of what she has fished out of the patient's stool over the last couple of months, which looks like she has passed some pretty impressive sized stones. Okay, so if we go all the way back to what Emanuel syndrome is, because that's sort of what I had to do to try and figure out what was related to what. So it's a rare chromosomal disorder resulting from an unbalanced trans 1122 translocation. It was first described in 1980 by two American researchers. And this picture is actually the patient, a picture of the patient shared with mom's permission. And this condition is there's multi-system involvement. These children have intrauterine growth restriction. They have postnatal failure to thrive as well. They often struggle with feeding challenges, and a lot of them require gastrostomy tubes. They have microcephaly and profound intellectual disability. They can have ear abnormalities associated with congenital cardiac lesions, as well as renal abnormalities. But what I did not find were any gallbladder abnormalities that were necessarily associated with Emanuel syndrome. And I did quite a deep dive to see if there was some sort of association. This was a case report and review published in a medical genetics journal last year. They were actually presenting their case, but also summarized some of the cases which had been reported. And I mean, there are just a couple of hundreds of children reported worldwide with Emanuel syndrome. And if we go to number 6, which is genitointestinal defects, it lists, of the case reports that have been published, diaphragmatic hernias have been reported, anal atresia, inguinal hernias, biliary atresia, microcephalics, and cryptorchidism, but no real mention of other hepatobiliary associations, other than biliary atresia. So it was not clear if the Emanuel syndrome and the multiseptated gallbladder had some relation, but on the fact that she had these abnormal abdominal sonars within her first year of life, I could only assume that this was something that was inherited or congenital in nature. So what is a multiseptated gallbladder? So it's also known as a honeycomb gallbladder, also an incredibly rare congenital abnormality. And this is characterized by internal septa dividing the gallbladder into multiple compartments. The first pediatric case was described in 1966. And again, I mean, in a recent case report and literature review in 2024, there were about 30 articles of children with multiseptated gallbladder, essentially describing about 37 children. So there's not a lot about multiseptated gallbladder. It is incredibly rare, and its etiology is also not fully understood. What we do know is that it is associated with other congenital anomalies, including congenital anomalies of hepatobiliary and pancreatic systems, particularly choledochal malformations. Those are relatively well described. And this is a small group of patients. It is also associated with cardiac lesions, congenital cardiac lesions, as well as congenital anomalies of the renal tract. So we know she has certainly cardiac lesions, and the etiology for hydronephrosis is still not clear. But as I mentioned, there's no clear association between Emanuel syndrome and multiseptated gallbladder. So as I mentioned, the etiology is not yet clear. There's some debate as to how it actually came to be. There are two hypotheses, and this is a diagram essentially depicting the two hypotheses, although the end result is essentially the same. So the first hypothesis at the top was described in 1970 by scientists in 1970, and the theory centers around incomplete vacuolization. So during embryogenesis, the gallbladder lumen normally forms by vacuolization of the solid endodermal gallbladder bud. But if the vacuolization is incomplete or irregular, then you have these persistent epithelial septa which remain within the lumen. These septa then divide the lumen into multiple compartments, which produces this multiseptated gallbladder. But a couple of years later, in 1993, another scientist or physician had a different theory after sort of reviewing these gallbladders at different gestational ages, and they felt that or supported this theory of excessive epithelial proliferation or folding. So essentially it's where there's, abnormal or exaggerated mucosal proliferation and folding during development, which leads to these ridges and invaginations. And these folds will progressively deepen and subsequently fuse, which results in the septations within the gallbladder cavity. And the end result is a multiseptated lumen resembling a cluster of locules. So these are the two sort of theories at the moment as to how a multiseptated gallbladder has come to be. And this is really what it looks like. A multiseptated gallbladder is at the top image is sort of on dissection, but this is how it looks like when it's removed. And we know that multiseptated gallbladder is associated with biliary stasis, and that puts the child at risk of also of calculi. And the presentation is variable. Some children are asymptomatic. It's an incidental finding. Some children can present with right upper quadrant pain. They may have nausea and vomiting. And in some instances, they may also have jaundice. The diagnosis is on abdominal ultrasound, but ideally MRCP would be the gold standard where available and where possible. Cholecystectomy is the recommended treatment as it results in complete resolution of symptoms. Okay, so looking at gallstones, because it was now clear that multiseptated gallbladder is potentially what put her at risk of developing the stones, which could have accounted for her symptoms. So although the prevalence of gallstones in children is much lower than that of adults, the prevalence is increasing globally. And in part, this is due to the growing obesity epidemic, resulting in more on the cholesterol side. And essentially the pathogenesis is that we know that normal composition of bile is made up of water, cholesterol, bilirubin, phospholipids, and bile pigments. When you have imbalances in the bile composition or the gallbladder motility, or any abnormalities in the mucosal factors, this can result in the formation of gallstones. So one of these factors is the supersaturation of bile. So when the cholesterol concentration of the bile exceeds the solubilizing capacity of bile salts and phospholipids, the bile becomes supersaturated with cholesterol. And this is the key initiating step in most gallstones, especially cholesterol stones. Nucleation of crystals is also an important factor in the development of gallstones in children. So the supersaturated cholesterol can precipitate or precipitates as cholesterol monohydrate crystals. And then you have these mucus glycoproteins which are secreted by the gallbladder epithelial. And this acts as a matrix which traps these crystals. And the accelerated nucleation leads to growth of crystals into essentially microliths or stones. Any factors affecting the gallbladder motility. So if you've got gallbladder hypermotility or stasis, such as anatomical abnormalities, like in this patient with multiseptated gallbladder, but other factors like prolonged fasting, pregnancy, TPN, this leads to bile stasis. And then stasis will promote further nucleation and aggregation of crystals, allowing these stones to essentially grow. And then if you have mucosal absorption and secretion changes, so if you have excessive absorption of bile salts and water, this will concentrate the bile, which further worsens the supersaturation. And then if you have any inflammation of the gallbladder, that contributes by altering the bile composition and promotes the mucus hypersecretion. So all of these factors can result in the formation of stones and also the growth of the stones themselves. In children, we divide stones into, stones can be divided into cholesterol and pigment stones. A bit of a busy slide, but it's just looking at the difference between cholesterol and pigment stones. So cholesterol stones are more common, particularly in the Western population, as I mentioned, because of the growing obesity in children, and there's an increase of cholesterol of children with gallstones, more specifically cholesterol stones, more common in adolescent girls. And it's associated with cholesterol hypersaturation, hypermobility, and nucleation factors. These stones have a cholesterol content of more than 50%. These are often solitary, white, round, smooth stones. They are not radiopaque, so you won't always see them on a plain film. And as I mentioned, obesity is a very important risk factor. Then you get pigment stones, which are often more common in children than cholesterol stones are. And these can be black or brown pigment stones. So black pigment stones are essentially due to hemolysis or cirrhosis from the excess unconjugated bilirubin, which will precipitate as calcium bilirubinate. Black pigment stones are usually black to brown in color. There's often multiple of them, usually a bit smaller, and they're composed mainly of bile pigment. And these are often children with hemoglobinopathies or children who've been exposed to quite a bit of TPN, or liver cirrhosis for whatever reason. And then your brown pigment stones are often associated with infections, biliary stasis, particularly parasitic infections. And these stones are brown to orange in color. They're often softer, greasy, smooth, and they're composed mostly of calcium bilirubinate. So in terms of the etiology of gallstones in children, you can divide them into hemolytic causes, non-hemolytic, and idiopathic stones. So your hemolytic causes, often these are your black pigment stones. And these are children with hemoglobinopathy, such as sickle cell disease and thalassemia. There are some recommendations that children with sickle cell disease sort of get prophylactic or preventative cholecystectomies because of the risk of stone formation. And it isn't always easy to tell the difference between uh, crisis versus any of the complications, a sickle crisis like an abdominal crisis versus any of the complications from gallstones. And then you have your non-hemolytic causes, so such as TPN and conditions that result in prolonged fasting. Children who've had ileal resection, so patients with short bowel syndrome or who've had NEC, or even patients with ileal disease, such as in Crohn's disease. Children with cirrhosis or chronic liver disease, any congenital biliary malformations can predispose children to developing stones. Drugs such as furosemide, the combined oral contraception, and an important one is ceftriaxone-associated biliary pseudolithiasis. So often with these patients, once the ceftriaxone has been discontinued, there may be a spontaneous dissolution of the stones. It's always something to look out for. I think ceftriaxone is used quite liberally in children. And so it's just something to bear in mind if there are stones associated. And then obesity and dyslipidemia as well. And then you have idiopathic stones, and you don't always find a cause. So in terms of the clinical presentation, it can be variable, and I quite like this table, which summarizes the different ways that stones can present in children, particularly dividing it by age group, because it can be a little bit more subtle in the smaller kids. So in infants, which accounts for about 10% of kids with stones, they can be symptomatic or asymptomatic. And if they are symptomatic, they can present with cholestatic jaundice. They may have a transient acolic stools. They may even present with sepsis. And then if they're asymptomatic, it could be an incidental finding on ultrasound for whatever other initial clinical question. In slightly older children, about 40 to 50% of them will present with the typical biliary symptoms of the right upper quadrant pain. They may have epigastric pain, which may or may not be associated with nausea, vomiting, and they may have some fat intolerance. A smaller percentage of these children have sort of non-specific abdominal pain, and some children can present with an acute abdomen. Often, if this is a complicated gallstones, they may present with cholecystitis, pancreatitis, or cholangitis. So this is just important as something to consider, depending on the clinical presentation. And then some of these children are actually asymptomatic. And then the older kids or the adolescents, which account for the large proportion of the as we mentioned, the cholesterol stones specifically, they may present as like the younger children. However, the right upper quadrant pain and fatty food intolerance is a lot more pronounced, probably not too dissimilar to how an adult would potentially present. In terms of complications, and this could sometimes be the first way that a patient presents. So they could present with acute calculus cholecystitis, which results from an obstruction of the cystic duct. So you have by the stones, and this leads to inflammation of the gallbladder, resulting in acute calculus cholecystitis. This obstruction causes a gallbladder swelling, followed by bile acid concentration and ischemia of the gallbladder wall. And sometimes this can be accompanied by bacterial infection. So these kids can be quite sick. These children may present with severe colicky, right upper quadrant pain, fever, and vomiting. They could also get common bile duct obstruction, which can present with more obstructive symptoms such as acolic stools, jaundice, and dark urine. They could also present with acute cholangitis as a result with sort of fever, jaundice, right upper quadrant pain, and they can present with pancreatitis. Very important differential in a child with acute pancreatitis, certainly with recurrent pancreatitis. And these children may present with epigastric pain, nausea, vomiting, and the amylase and lipase can be elevated more than 3 times upper limit of normal. In terms of management of children with gallstones, this would depend on their age, on the type of stones, and then the symptoms or complications that the child has. What's important is that asymptomatic children need to be surveyed and observed until into adulthood. And that will help make guide what further steps that one should take, but they should continuously sort of follow up and be observed. Children who are symptomatic and those who have complications require treatment. We have medical treatment. Ursodeoxycholic acid, I think, is well known. I will chat a little bit more about that in the following slide. But if you find a cause, like say, for instance, you've got a child with sickle cell disease, we'd want to optimize their disease. A drug like hydroxyurea, among other preventative measures, would be first point of call. So interventions such as ERCP is always very tricky, particularly in smaller children, just due to the small caliber of the bile ducts relative to the probe size. It's increasingly sort of not really recommended in smaller children due to the risks, particularly of pancreatitis. If you've got, a bigger child, an adolescent with a physical, like good size, and you have the right expertise and the appropriate equipment, it can certainly be attempted. But essentially, increasingly, laparoscopic cholecystectomy is really the gold standard for children, for all children with symptomatic gallstones. And I think increasingly that's really where the move is for children with symptomatic gallstones. Okay, so just chatting a little bit about ursodeoxycholic acid. So this is the drug of choice for medical management of gallstones in children. So its mechanism of action, it reduces the cholesterol saturation in bile. So it decreases the cholesterol secretion into bile from the liver, and it also increases the bile salt concentration, which results in the bile being less supersaturated with cholesterol, which prevents new stones from forming, and it allows for gradual dissolution of existing cholesterol stones. It also improves cholesterol solubilization. So it's a hydrophilic bile acid that integrates into the bile acid pool. And then this increases the ratio of bile salts and phospholipids relative to the cholesterol, which stabilizes the micelles. And so then these cholesterol crystals dissolve back into micelles a little bit more readily. It enhances gallbladder motility. So it increases and improves the gallbladder emptying. It reduces stasis, which limits then the crystal aggregation and also limits the growth of any of the stone growth. It also has cytoprotective effects, both in the gallbladder and also the hepatocytes. So this is really how ursodeoxycholic can be beneficial. It's important to note that it's not applicable to all stones. So it's mostly recommended for children with cholesterol-rich stones that are non-calcified with a diameter of less than 20 millimeter. And it's important to demonstrate a patent cystic duct. And the recommendations really is that you should continue ursodeoxycholic acid for a period of about 3 months after you've demonstrated complete stone resolution. And if you see minimal or no change in the stone diameter after a period of about 6 to 12 months on urso, this really indicates a poor prognostic indicator for dissolution of stones. You may never be able to get those stones to go. And so that may be the point at which you discuss surgical, management, namely cholecystectomy. So as I mentioned, the gold standard now for symptomatic or complicated gallstones in children is a cholecystectomy. Cholecystectomy is indicated in children with symptomatic stones, with complicated obstructive disease. And if you really tried, you've optimized your medical therapy for that period of about 6 to 12 months, and you have this persistent right upper quadrant pain, or you're not really managing with the dissolution of stones, then it's indicated in those children as well. The laparoscopic approach is what is recommended rather than open cholecystectomies. And the outcomes are actually much better in children who've had elective cholecystectomies than children who maybe run into trouble and then you want to do a cholecystectomy. And this was a really nice review of cholecystectomies in children, and looking at the indication and timing of children with cholecystectomies for gallstones. So it starts really right at the beginning with the diagnosis. And this is a nice approach to children with stones. You start with your abdominal ultrasound, of course, where that's your first line investigation to really confirm the presence of stones. But MRCP is very useful to assess for the anatomical causes, and also assessing for complications. And then your baseline bloods being your liver function test, amylase, lipase, and CRP. If you have a child with asymptomatic cholelithiasis, then you want to rather opt for conservative management. And then surgery, even in an asymptomatic child, is perhaps something to consider if you've got a child with a hemoglobinopathy or hemolytic disease of another cause. In symptomatic children who do not have complicated stones, excuse me, then you want to opt for an elective laparoscopic cholecystectomy. These children have the best outcomes, the shortest operative time, and the length of hospital stay is reduced. However, if you have a complicated cholelithiasis, then the recommendations is actually to rather delay surgery for a period of 14 days, to first start with your initial conservative management, so antibiotics, fluids, analgesia, and so forth. If you have cholelithiasis, then ERCP if they're old enough. But this, as I mentioned, is just very tricky in small children when you're trying to balance risks and benefits. But really the general principle is to delay the cholecystectomy until the inflammation has settled. And it actually gives some really nice guidelines, looking at the surgical timing. So as I mentioned, the elective is sort of the best outcomes are when you take out the gallbladder electively. If early cholecystectomy, if you've got complications, day 1 to 4, that's really if your backs are against the wall, and the child is very unstable. But ideally, you delay the surgery until about 14 days. Okay, so back to our patient. So she was started on ursodeoxycholic acid, and she had quite a remarkable clinical response. She sort of went from admission every 2 to 3 weeks to long stretches without hospitalization. She had one admission with cholecystitis in 2024 and has actually not had any further admissions for anything related to her tummy since then. So it's been quite great for her quality of life. We did discuss cholecystectomy with the pediatric surgeon and with her mother. And it's a very tricky one because, she had quite a lot of comorbidities, coupled with quite a lot of drug interactions and allergies that she had. And I think mom was quite pleased with how she's hasn't really been admitted to hospital and been sick, that I think between her and the surgeon, the decision was made to wait for now. And, she's gaining weight and she's gaining length. And she now looks like this. But her risk factor persists. with the multiseptated gallbladder. And so her risk of stones and complications, unfortunately, has not necessarily changed, even though she looks much better.
And Kathy came home early.
Cute.
She came home early. She said she had a headache, so she went to bed. And so she had a.
Thank you very much, Dr. Ndhlovu. Very interesting case and rare case. I've been enlightened now. I know all about Emmanuel syndrome. But also, it was a wonderful, comprehensive overview of the pathophysiology of gallstones, the clinical presentation, and the management as well. I know that there's some questions in the chat box, and I don't know if some of the questions have already been answered by your latest slides. But if we refer back to that.
The last slide?
No. The questions by Dr. Akui Asomban. I don't know if you want to direct the questions to Dr. Ndhlovu, or should I read the questions from the chat? You can unmute yourself if you want to ask the questions directly. But the one question relates to the, is there any risk? We are aware that, for example, with choledochal cysts, there is a risk of malignancy. Is there an increased risk of malignancy in this multiseptate gallbladder?
So I have not seen anything that speaks to the multiseptated gallbladder and malignancy risk. In all of the children that have been described in the case reports I've read, they all had their gallbladders removed. So, yeah, I'm not sure if, what her risk would be should this gallbladder remain. Yeah.
And then the other question relates to this type of multiseptate gallbladder. Do you find it in isolation? Can it be found in isolation? Or is it usually part of a syndrome, specifically Emmanuel syndrome?
So I could not find any association between Emmanuel syndrome and multiseptated gallbladder. But having said that, they're both very rare conditions, sort of separately. So the combination, I think, perhaps she's somebody that we should maybe, put out there as a case report. But there is nothing at the moment that really links the two. The thing is, the only reason why I think it's related is that she's had that in her sonars in the first year of her life. But we do know it is associated with the other congenital abnormalities, of which she has several. So whether she had it because, as an association with her other cardiac lesions or the Emmanuel syndrome, I'm not sure. But it is probably oral, the Emmanuel syndrome, perhaps it has not yet been described, but we know biliary atresia is described, but there probably are other associations which will become a bit clearer as more children get diagnosed with Emmanuel syndrome. And her diagnosis, they had to send the genetics to, I think, to the US. It took a while. It was not an antenatal diagnosis. She was diagnosed as an infant. So as she got a bit bigger, yeah.
Okay, and there is a query about the management as relates to symptomatic versus asymptomatic. There's a comment in one of your slides, not the final slide, but one of the previous slides, that there is conservative management in terms of continuous monitoring. So the question is, what are you waiting for? What are you looking for? And is it worthwhile in terms of our resources?
Yeah, so perhaps in our setting, getting ultrasounds every 6 to 12 months may not be feasible. But I think if you have persistent stones over a long period of time, you may see subtle changes, thickening of the gallbladder before symptoms occur. And perhaps you would do something. I think in our setting, we would probably be less inclined to take out a gallbladder in a patient who's fine. But they certainly don't advocate for chronic use of ursodeoxycholic acid, for instance. You want to give it a trial, see if you can get the stones to dissolve. If you can't, you take out the gallbladder to prevent problems later. Whether that's applicable in our setting or not. I think in this particular patient, I mean, she was symptomatic. Now she's got no symptoms. She's completely asymptomatic, but her risk factor remains, and she may have a severe complication in the future. And I think that's really what one wants to prevent as best as possible.
Okay. Are there any other questions from the participants? I can't see any hands being raised. Let me have a look. Just to ask, are you planning to continue the ursodeoxycholic acid indefinitely in this particular patient?
So I think this is the dilemma, and why I say her story is not yet concluded, is she does need a cholecystectomy. I understand mom's reluctance. I think she's enjoying her child not being sick, not being in hospital. She also understands the risks. It's a conversation that is ongoing, but until we can take that gallbladder out, I would be, very reluctant, and so would mom, to stop the ursodeoxycholic acid, because it made like a near immediate change for her. So in follow-up sonars, she's got small stones here and there, but they're not causing problems. She hasn't had jaundice, so I think it will stay until take out her gallbladder. I don't know.
Yes, the reality is that the stones will obviously recur again once you stop the deoxycholic acid. In terms of the pictures that you showed of the gallstones, they were multicolored. So what type of stones do you think they were predominantly?
So assessing her risk factor, they most likely are cholesterol stones. Her problem is probably the hypermobility from the anatomical abnormality of her gallbladder. But I can appreciate that there were different colors, but they were predominantly that yellow, palish color. Yeah.
I think the response to deoxycholic acid also suggests more cholesterol type of stones, predominantly cholesterol type of stones. One other question on the chat was, what is the mechanism of cholelithasis in obesity?
So it's relating to the cholesterol component, and they're more predisposed to the cholesterol stones from any dyslipidemia that associated with obesity and overweight.
Okay. I don't see any other questions. If you do have any questions, please unmute yourselves and ask.
Yeah, so if mom never wants to do the cholecystectomy, if she says, look, no, then it is a difficult discussion. Is it safe? Is it scientifically sound to continue the IRS? And I don't really know the answer to that question. I don't know if other colleagues have faced this predicament. But that's sort of where we are.
Okay. I don't see any other questions. Thank you very much. Very insightful and very interesting presentation. Well done, Lesego. I just want to say thank you to all the participants. Thank you to the speaker, of course, for the wonderful presentation. Thanks to to Echo India team. Thanks to Echo UNM as well. Recordings are available on the Gastro Foundation website. Thanks to the Gastro Foundation, and thanks to the sponsors as well. And we're looking forward to seeing you next week when the discussion will be pancreatology. Thank you all, and good night.